Good morning, good afternoon, good evening, whatever time you guys are watching this. This is Dr. Kusuma from Suria Plastic Surgery. For those of you who missed our most recent YouTube and our social media post on a post facelift and eyelid patient, you guys should watch it when you get a chance because it's very telling about what is possible today, okay? And she spoke, very candidly without any canned speech of how she felt about the surgery, what type of anesthesia, and why she chose a certain type of anesthesia. And this created a bit of a conversation. This generated a little bit of conversation amongst the audience that has seen it. And the topic of interest was the type of anesthesia and why. Because it was, to do a face neck surgery under local anesthesia is not easy. It's a lot of work and it requires patience and a proper way to do it so that, if the patient's comfortable, the surgeon is comfortable, and on top of that, do the eyes at the same time as well. So the topic of conversation was really anesthesia and how and what type of anesthesia is out there, because there's a lot of confusion about that also. Okay, so I'm going to take this time to explain how a patient should think about the various types of anesthesia that are used in specifically aesthetic or cosmetic surgery. I am not talking about hospital-based surgery where they do heart and belly and brain and all kinds of different things. I'm purely focusing on outpatient-based aesthetic or cosmetic surgery procedures, which I do every day. And I've been doing for 16 years, and this is the way I've done it always, and it's worked very well for me. So I'm going to explain these things to you guys, okay? Hopefully this will clarify all of the questions you have about anesthesia. So when anybody thinks about anesthesia, right? So please indulge me because I love active teaching or active discussion without a canned talk because it's very authentic. So anesthesia goes hand in hand with safety. I would say this is the number one reason, number one concern that almost every patient has. Because in a way, when you think of anesthesia, essentially you are letting go, right? You're letting go of control over your body. Because when you are asleep, essentially you're handing over your body and mind and soul, literally in a sense, to the surgeon that you trust and the team that the surgeon has that you trust. And it's very difficult for patients to do that. I mean, because especially in an elective case, because you don't necessarily need the surgery, right? So you want to make sure that you put your trust and faith and confidence in somebody or an office that can take really, really good care of you. And that's the number one reason people fear surgery in aesthetics or cosmetics, okay? That's the safety factor. So let's talk about the safety. What can lead to things going awry? Okay, the first and foremost is make sure that the patient is healthy. Okay, the patient needs to be healthy, and for that to happen, you do a medical clearance. So you typically want to check their heart, you want to check their labs, you want to check their lungs, you want to know their history, any unusual things going on. And usually you want to get consultation from primary care. Okay? Because the one person, kind of like the quarterback you can think about for your general health, is really your primary care, not your plastic surgeon, right? And so most of the time, there's of course anesthesia criteria, which I'm not going to get too detailed into, but by and large, after 40 years of age, people should make sure that their heart is okay. So you may want to get an EKG. If there's something that's discovered, they may want to get additional studies. But for most 99% of the time, just a simple EKG would probably do. Okay. Labs, again, make sure there's no bleeding disorders. Make sure that the liver is okay. Make sure that your electrolytes are okay. So you get what we call a basic metabolic panel or a complete metabolic panel. These days a lot of people drink socially and they smoke socially, and so we want to make sure that we check out their liver and things of that nature. Okay, so labs, lungs, sometimes you need a chest x-ray, maybe called CXR, and you have to the primary care of course listens to the lungs with a stethoscope and may want to do other things. And then history is very important. Has there been previous, history of anesthesia problems? Has there been previous trouble with sleep apnea? Whatever the case might be, bleeding disorders, anything like that. And all of these have to be screened, and you do not want to take a shortcut here, because the goal here is safety, right? And if you're really concerned about safety, you have to invest in your own safety, which is to make sure that you get this done just for your own peace of mind and your family's peace of mind. And we do that on our end because we never want to put anybody in jeopardy for any reason whatsoever, right? We want to make sure that everybody that comes here is happy and leaves happy, and healthy and happy, right? So we want to make sure that we do our part. But sometimes patients may not want to do this because it's a little additional cost, or may take a little bit of time, or maybe they have some difficulty getting into a primary care's office because appointments are backed up. But it's still important, okay, that we do this because it's for your own safety. If there's a problem, with the primary care, because sometimes people may not have a primary care, in that case, we recommend 2 or 3 physicians that we work with who have a very fixed fee. It can sometimes go through insurance, sometimes out of pocket, but whatever it is, we've made it very easy for patients. So this is the number one thing that we do. The second thing is check the procedure length. Okay, for elective surgery, we want to stay around 6 to 7 hours on the top end maximum. Okay, in other complicated surgeries, like I said, for heart, lung, other things, the hospital is a whole different ballgame. We don't want to go there, so we can't compare all of that to this. We're talking about healthy patients we've screened, and we're doing elective surgery, which is not as demanding on the body as if somebody opens their chest or their belly, which is what happens in the hospital setting, right? We cannot compare those two. So don't read that and apply the same thing to this type of surgery, because it is not the same thing. Okay, so in the second phase of it, we want to make sure the length of time is adequate. The maximum time that we want anybody to undergo elective surgery is 6 hours, really at the top limit, but because of some minor little delays, it may stretch to 7, but we don't want ever to be over that, because there is no reason to take that additional risk, because the longer you go, obviously the potential for risk goes up slightly, and we don't want to do that. Okay, so the length of surgery. The third one is facility. Okay, it needs to be accredited. Okay, it needs to be clean. It needs to be well maintained. It needs to have the proper equipment. It needs to have all the necessary backup plans. And should be affiliated with the hospital close by. Okay, so these are things that we make sure we take care of. So nowadays it's become pretty common. People get some advice from a television show or a talk show, and they come with a checklist. Actually, doctor, how many surgeries have you done? Where did you train, etc., etc. But these are good anesthesia checklists that you have to go through. Okay, the facility has to be accredited, and the accreditation is from the accreditation bodies, which we don't need to go to. It needs to be very clean. It needs to be well maintained. There needs to be proper equipment, not like rusted old kind of hodgepodge kitchen sink type of equipment. We need to make sure that the facility has backup plans, meaning if something doesn't work properly, they have a backup machine or backup, whatever that's necessary. And we also want to make sure that the facility itself is accredited and close to another facility, a hospital, in the very unlikely circumstance that you have to transfer somebody to the hospital. Okay, I can tell you, at least in my practice, in the last 16 years that I've been practicing, I've never had to do that, but it's good to know that you have that facility available. Okay, so these are the things, basic things that everybody has to know. The second phase of this video is going to be about the various types of anesthesia itself. And that's also a good educational video that we should discuss. So I want to take this extremely seriously, this portion of the previous things that I spoke about, including accreditation, facility, etc., right? Because those are things that are inanimate. Facility is an inanimate thing. Like, anybody can maybe, can build something for you, can buy a piece of equipment. It doesn't require training. It doesn't require experience. Basically, it's an inanimate object. The facility being clean, you have a cleaning crew come and clean it. Nothing special. Anybody can do that. What you cannot replace ever is people, right? People. In our case, we call it staff. Obviously, clinical staff, right? I want to make this its own entity. I cannot stress again enough that the pieces of equipment we use, the implants we order, the cleanliness of the facility, accreditation is just an inanimate process. That's all it is, right? They're objects. They're not people. However, for anesthesia and surgery to go well, okay, people are what matter because they're the ones that are taking care of you, the patient. So the surgeon, the front office, the nurse who's in the operating room, the circulating, what we call the circulating nurse, the scrub nurse, the anesthesia personnel, everybody should be trained and on the ball all the time to make sure that things are safe. This really is the key to making sure that anesthesia is safe, because if people are not well trained, if people, no matter how good a facility they're working, it doesn't matter, right? If people are not working together as a team, no matter how much equipment you have, you're not going to find it in time to do what you need to do, right? If the surgeon is not properly trained, then he or she's not going to be able to lead the team properly. If anesthesia is not on top of the game, then they're not going to be able to make sure that they're monitoring, second to second what's going on. So having a good team is really important. So what is the team that is in the operating room? You obviously have the surgeon, captain of the ship, right? That's how it's referred to. Surgeon, whoever that is. The next one is anesthesia personnel. Okay, so anesthesia personnel. Then you have the scrub nurse. Then you have what we call the circulating room nurse. So in most cases, this is the team. In some cases, you now have assistants for either the surgeon or for anesthesia or for the scrub nurse or an extra person to help, because there's lots going on, right? You sometimes have equipment professionals. So if there's a very specific, very high-end, complicated piece of equipment that is being used, you really want to make sure that the professionals who work with that piece of equipment are there, because if there's anything that's not quite working, you want to know that they're there to support if necessary. Sometimes there's students who are in training. Okay, so the typical team, right, is really these four. The typical team is the surgeon, anesthesia personnel, scrub nurse, circulating room nurse. Sometimes you have assistants for various, sections or departments or people. You sometimes have equipment professional and students. And when people take a break, there's some, turnover of the nurse or for a short period of time, but usually the same crew that, usually works the whole case. This is another important aspect of doing surgery outpatient in a plastic surgeon's office, which I love. This is like my home, right? This is like my shed, my tool. This is where I spend a lot of my time, and most surgeons feel that way. We make sure that it is the way that we want it, because when we go to the hospital, I have no control over that. So this is my home. I'm going to keep it as good as possible, working up to date, etc. The second one is I hire the people that I want to work with. So I know that there's consistency in staff. So there's no new people coming, don't know what's going on, I've never done it, and there's a lot of chaos. So I make sure that I have the same consistent crew, same experienced crew. Okay, the patients that come in are also very carefully screened, so I don't do trauma or what we call dirty cases where there's a lot of contamination and things like that. These are all very clean, planned out, thoughtfully planned out cases. So very specific type of patient population comes there. We don't bring infections in here. We don't do all kinds of crazy stuff into this room, right? Because they're all healthy patients in elective surgery. So all of that has a role. It's very private. It's very calm. It's very, very relaxing because it's under our control. There's not a chaos going on like at the hospital with overhead, screaming and lots of people waiting. It's a very, very comfortable home-like setting. So there's a lot of advantages. But anyway, this is the essential team that is in the room, which I think is the most important aspect of all of the safety aspects that we're talking about today. Okay. So this is part 2 of our conversation regarding anesthesia under the cosmetic surgery setting. I'm going to stress this again. Please do not compare hospital-based anesthesia where they're doing sick patients, they're doing heart patients, lung patients, abdomen or belly patients, trauma patients, which is a whole different ballgame entirely. We are doing surgery on otherwise healthy, active, young, conscientious people that are doing as much as they can to look and feel their best. So it's a very different ball game in cosmetic surgery. Okay, so I want to because there's a lot of information sensationalized out there about complications from anesthesia and such. And the reason I thought of doing this is because I just posted a video about a recent patient that I did a face and neck and eyelids on, and she chose to do it under local anesthesia. And one of her fears was anesthesia, and that created a lot of conversation about the types of anesthesia due to that post. So I just want to do this as a follow-up video. Okay, so the types of anesthesia. I'm going to keep it simple so you guys can understand. The first type of anesthesia is local anesthesia, okay? Local anesthesia. People confuse this with something else as well, but I'll explain. Local anesthesia means, for example, so if this is the face, right, and you're working in this area of the face, you essentially numb up only this part of the face. So it's local because you're localizing the area that you're working on and you're numbing it up right there. You're not putting something in their arm. You're not doing anything with tubes, none of that, to make your brain and body go to sleep, right? You're only working on the area that is the problem area. That's why it's called local anesthesia, okay? If you do a bigger area, you numb up a big area. So that's basically it. You're fully awake just like I am right now. You sit on the table, you lie on the table, you move on the table, you're communicating with me, or whichever surgeon is working with you, and you're communicating with the staff, and at times you're expressing something and the surgeon is telling you to do something, etc. So you're fully awake, fully conscious, etc. And so there's nothing else given, and all we use is something called lidocaine, which is a medication that creates numbness. So you don't feel any pain. However, you still can feel pulling and tugging and stretching and maybe some tightness perhaps, but you should not feel any sharp pain that makes you feel uncomfortable. Okay, so that's important to know. You may feel a little cold or whatever else, but you should not feel any pain sensation. So the tightness and stuff is okay. The other thing it also has is something called Epi Epinephrine. Okay, this causes heart rate increase in some patients. The reason we use these combination together, okay, is because this generally causes all of your blood vessels to shrink and tighten up, like really tight. And when that happens, the anesthesia, which is this one that causes numbness, doesn't go and disperse everywhere. It keeps it acting for a longer period of time. In addition, it also creates less blood loss, obviously, right? Because if the blood vessels are really clamped down, there's less likelihood of them bleeding out. And so the operative field where you're working is very clean and you don't have to worry about lots of bleeding. Many times patients have this experience because of they worked at a dentist's office or a dermatologist's office, and sometimes they obviously talk about their heart kind of racing, and they get fearful of it or anxious with it. But it's a very short-lived situation, and if you do some deep breathing exercises as we kind of do this, it helps a lot and relaxes people quite a bit. Okay, but if you want to make sure that the operation goes as cleanly, as nicely, without minimal to no blood loss, it's necessary to have some epinephrine. If you remember, or maybe if you don't remember, or if you don't know, whenever somebody has any heart issues, this is the medication that's actually given to jumpstart the heart back up. It actually increases the heart rate, okay? But locally, it constricts the blood vessels and causes very little blood loss, and can have a long-term acting of the local anesthetic there as well to some extent, so because things don't leak out and bleed out and stuff like that, okay? And so those are the things that we use. So now we could do local anesthesia is a second one, plus some oral medications. Okay, so for the local anesthesia, it's the same stuff here, right? So one other thing I'm going to talk about here is that you can use lidocaine, which lasts approximately 1 hour. Okay, 1 hour lasting medication. We also have something called Marcaine. You don't need to memorize these, obviously. This can be 8 to 10 hours lasting medication. So we mix these plus the epinephrine, right? So with all of these together, you now get the short-acting one that acts immediately, that gives you the short-term pain relief to get started. This one starts working about 20-30 minutes after, and this kicks in, and this can last 8 to 10 hours. And this, obviously, we talked about already, that gives you localization of the medication, so it lasts longer, and it also constricts the blood vessels, like I said, so that it doesn't bleed as much. Okay, so this is the local, mixture, so to speak. And when we do long operations, this is how we mix it, because we need this to kick in by the time this is worn out. In short procedures, this is all that's necessary, because you don't need a long-acting medication to do the operation. Of course, you can always put this in all procedures, because if you want post-operative pain relief, since this lasts 8 to 10 hours, it's also not a bad idea to mix it in all the procedures. Okay. In addition, we can also add something called bicarbonate. This decreases the acidity of this mixture, okay? When that happens, that also decreases pain further, because one of the things that causes burning is the acidic nature of the medication. That's just the way these are made. So if you neutralize it to some degree with this other compound called bicarbonate and do this mixture, then you decrease a little bit more the injection portion of it, okay? So these are the mixtures. So now it's important to talk about the oral medication, okay? What are we actually trying to control? We're trying to control 3 things: anxiety, memory, or amnesia, and pain, right? Called analgesia. Okay, so anxiety we're trying to manage as much as possible. Amnesia we're trying to create, and analgesia we're trying to get. These are the 3 things we're trying to do with delivery of any type of anesthesia, for that matter. In some cases, which we're not going to talk about it here, we're trying to decrease movement or activity as well, right? I can put it there, maybe activity. By activity, I mean movement of muscles and things like that, so patients are common saying. So you can see anxiety, amnesia, analgesia, and activity, right? But in local anesthesia cases, the patients are cooperative because they're awake, so I don't need to worry about it. But when patients are asleep, we may need to work on that as well with some medication. So these are the things that we're trying to control in any type of anesthesia, for that matter, okay? So what are the medications that we give? For anxiety, we give a medication. These are called Xanax. It could be Ativan. It could be Valium, etc. Okay, these are the medications we give for anxiety. For amnesia, there's other medications. You can give something a little stronger. You can give a narcotic sometimes, plus this, which can create some amnesia, and a lot of times people don't remember it. For analgesia, we already talked about this, right? In addition, these pain medications and narcotics can also give you some pain relief. The last thing that I'm going to talk about in this category is a gas. Okay, there's a gas called nitrous that's used in dentist's office most often. That's how actually it became popular, because that's what they typically use to kind of make people disassociate from pain, essentially. So they're awake, they're talking, but they feel something, but they don't associate in their mind with pain. So they're feeling something, but they don't know what to make of it. So technically, it also gives them pain relief because they don't remember it and they don't know what's going on, right? They're awake though. They're awake and they're talking. So we give them, and we use a machine called ProNox, NOx for nitrogen and oxygen, and so ProNox is that. And so this gas essentially something that we give you that you put in your mouth and you breathe it like you're breathing pure oxygen and pure nitrous into your lungs, and that's going to disperse through the body into your brain and cause you to disassociate, okay, from the pain sensation. So this is something that we started using a lot with all types of procedures now. We use it for fillers, we use it for Botox in some cases, we use it to inject when we're injecting this, which is really the most painful part of the operation, and we can even eliminate that now with these medications and with ProNox. So essentially the discomfort that used to be associated with the local anesthesia now can be almost fully eliminated with these kind of techniques. And these are all medications you take with a little bit of water. And since you're awake, you can eat before you come to the procedure. You don't want to eat a heavy meal, but you can certainly eat and drink and whatnot. And so that also makes people comfortable. And now you're not losing control in a sense. And that makes people a lot more, in their mind feel safer. Although the other techniques that we talk about are also equally safe or better, but this is just something that patients feel like they have control over, which is an important thing for them as well. So this is the technique. So usually we give this about 30 minutes prior to starting the procedure. So we have the patient come in, you sit down, you take these medications with some water, you relax for 30 minutes or so, then you start feeling a little bit of relaxation, maybe a little sleepy, drowsy, and then when we go back, we start with the ProNox, gas that you start breathing in, and then 2-3 minutes later, 5 minutes later, we start injecting all of the medications, and then you're good to go. So it's a very controlled, very thoughtfully designed process with trained staff, okay, that is going to make sure that you are as comfortable and as safe as possible. All right, so we talked about pure local anesthesia. We talked about local anesthesia plus oral medications. We also talked about local anesthesia plus oral medications plus the nitrous gas, right? Those are the things that we've talked about. The next aspect of it I'm going to talk about is called IV sedation, sometimes referred to as twilight. Okay? In IV anesthesia, it's right there, right? Essentially, we are now going to use medications that are going to be administered in almost all cases by an anesthesia professional into the blood vessels of the patient. Okay, so this is for those patients who really don't want to know what's going on. They don't want to talk, they don't want to know, they just want to wake up and know that it's done. So, however, even in this setting, we are not intubating, not putting breathing tubes. Okay, we're not paralyzing. No gases, heavy duty. All right, this also is maybe one step beyond the local anesthesia plus oral medications, because these are all going to be administered through IV. So we're definitely not using, breathing tubes in people. We're not putting on machines. Right? So we are not, giving medications to paralyze patients. We are not giving any heavy gases that are generally given. And this is very different than nitrous. Nitrous is a very low end medication, but we're talking about heavy duty gases that really cause anesthesia, that we're not giving any of that. And we're not putting people on ventilators during this surgery. They're still breathing on their own. Important to know, patient still breathing on their own. Important to know. Okay, this is with IV anesthesia. And I use this technique a lot. Okay, so in my practice, for a lot of the elective cosmetic surgery, whether it's facelift surgery, eye surgery, some small amount of liposuction, lipocontouring, breast surgery, anything like that, I almost always use IV anesthesia. There is no reason, in my opinion, and other surgeons may differ, who may want people to be on a breathing tube, on a machine, at a hospital setting, etc., which is completely safe and fine to do as well. I just prefer, because for the last 16 years, I've done it this way. I have a very experienced crew. I've gotten really good at it, and my staff has gotten really good at it, and our facility is made for this kind of stuff. So we really rely on this technique, and we've done it extremely safely for thousands of patients. Okay, so this is IV anesthesia. So these are the things that we don't do. What do we do? Okay, let me just wipe this off and actually put it down here. What are we using? These are the things we're not using, right? What we're doing is giving propofol, the white medicine. Sometimes people talk about the white chalky looking medicine that's given into the IV. Okay, you put an IV in the blood vessel, the vein of a patient in either arm, both arms, whatever. Then we give propofol, which is a very relaxing medication. Like, for example, when people go get a colonoscopy or have some minor procedure done, that's one of the most common medications that's given all across the world, specifically in the United States. It's very, very safe. I know some of you may associate it with Michael Jackson, but he was using it for the wrong purposes, right? We don't want to compare that with them again, because he was excessively using it without any supervision and whatnot. He was trying to do something at home and crazy stuff. But this is an extremely safe medication. It has a very quick onset of action. So as soon as you put it in the blood vessel, it starts working very quickly. And as soon as you turn it off, it goes away as well. So people wake right back up. So it's a very quick onset offset type of medication, which gives us a lot of control. And also to titrate the medication. We also sometimes give blood pressure medication if needed through the IV. Okay, sometimes for the heart rate as well, and sometimes pain meds, right? Sometimes we give nausea medication if needed. So, I mean, based on the need and the situation, since we already have an IV, now the anesthesia personnel has lots of flexibility to give medications, because the patient doesn't have to take it by mouth and whatnot. And usually when you take it by mouth, the onset of action is longer. With the IV, it's pretty immediate. So many times we can, second to second monitor patient, because that's the only person we're taking care of at that moment. We don't have other people waiting. So we're able to check and make sure that they are comfortable and sleepy enough, that their blood pressure is good, that their heart rate is good, that their pain is well controlled, and they have no nausea, and they're just kind of sleeping and dozing off. And we obviously monitor everything, right? We monitor oxygen levels, we monitor the heart rate, we monitor the blood pressure, we monitor breathing, THI in breathing, what we call how much gas is being exchanged. So we are able to check this second to second, but most importantly, we're watching the person actually, because that's the only person that we're taking care of. So we can very closely titrate this. So in my case, okay, this is what I use a lot of. But lately, as I've just talked about, I've been doing a lot more, than I ever used to do. All of these procedures that I do under IV anesthesia, also with oral sedation and nitrous that we just spoke about. So when patients come in and they want to do it awake, we have a choice. But if patients want to do it sleeping, we have a choice. And I also will have some input or recommendation, because if I see the person, they seem calm, they seem relaxed, they seem confident, they seem okay, that's a very good option to do it under local with the oral sedation, right? Oral medication. But if I find that the patients sometimes are just anxious, they have some phobia, they just don't want to know, they don't want to hear sounds, they don't want to talk, they just want to rest and wake up, this is an extremely good way to do it as well. So there's a lot of discussion that happens as to what choice people make. Okay, all of this is also done with safety as our number one priority. Okay, safety, 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 no compromise there. The same medical clearance that we talked about applies here, and we're going to do the same type of protocol with the proper equipment, proper staff, and all the rest of it. So this is called IV anesthesia, and you can do almost all plastic surgery procedures with this technique as well, at least in my office. So one aspect, financial aspect, is also something we need to discuss, right? The overriding aspect that we should always be concerned about is safety. No shortcuts, no compromise on that, right? But this is a real concern for some people. So this type of anesthesia is generally IV anesthesia, is typically a bit more expensive, but local is a bit less, right? So cost also has a role in and every center probably has different pricing. You just have to check with them, but there's a cost factor as well. But that is not the basis really where decisions should be made, because again, you don't want to do something because it's cheap. You want to do it because it's the right thing for you, and it can be done in a good place with good people and safely. I hope you guys are hanging in there with me, just so you get very confident about what you have to know to make some decisions about anesthesia in elective cosmetic surgery, okay? The last one I'm going to talk about is full general anesthesia. It's termed GETA, okay? It stands for General Endotracheal Anesthesia. Okay. All right. This is probably the most involved, and some people say maybe the safest based on who you talk to, anesthesia, because you are essentially given a breathing tube. You're on a breathing machine. You may be getting gases. You're getting IV medications. And you are basically being taken over so that the surgeon and the anesthesia crew has 100% control over your entire physiology of your body. So we're regulating your breathing, again, breathing, oxygen, your carbon dioxide levels, controlling heart rate, controlling blood pressure, controlling pain, controlling activity. And many times they may be paralyzed also. So patients don't fight, and it's easier for the machine to do what it needs to do, or the surgeon doesn't want the patient to move for whatever reason, etc. So this is the full gamut anesthesia, and it's got 100% ability to control, because there's also clearly an IV put in, maybe even two, so that a lot of medications can be given to help anesthesia is really regulate and manage. So what are the types of cases that you need this? For example, if you do a tummy tuck, you may want this. If you do a very long a liposuction case, you may want this. Sometimes, when you do complex breast surgery, some patients want this. For reconstructive plastic surgery, sometimes patients and doctors want this. And some doctors just feel like they should do it this way for everything, even for facelifts and things, because that's just what they're comfortable with. And sometimes this is done because the surgeon doesn't have an operating room in the office, and they have to go to an outside surgical facility, and there they only offer certain type of anesthesia in many cases. They may do IV anesthesia, the one before, but they may offer this as well. In that case, usually the anesthesia personnel makes the decision of what type of anesthesia to give, and therefore the surgeon may not have the control that they want. Okay, but this is an extremely safe way to do it. Of course, there's other facilities now involved. You have to now deal with the hospital or the surgical center. You have to deal with a different crew, different staff, which is perfectly fine because they're also trained. But this is the last and fully involved type of anesthesia that is also used by many surgeons very safely and very successfully across. All right, so this is the last part of the anesthesia. So I hope you understand the local anesthesia with nothing else, local anesthesia with oral medications only, local anesthesia with oral medications and ProNox or the nitrous gas and oxygen, the IV anesthesia we talked about, and the full general endotracheal anesthesia we talked about. Of course, the cost implications we also talked about. The simpler it is, the less expensive it's going to be. But by and large, all of these are safe ways to do it. And everybody has their own bias or feelings or opinions about it, but that's why, the whole package counts. The facility, the surgeon, the staff, all of that counts in safety. At least I can confidently tell you at Suria Plastic Surgery, under my guidance, we do this under IV anesthesia and local anesthesia plus oral medications and ProNox gas all day, every day, and we do it very safely. We do it very, very well.